This episode of The Benefit Whisperer is brought to you by Route 3 Insurance and Financial Services, where smarter benefits begin. If you're tired of rising healthcare costs and opaque insurance contracts, Route 3 is here to help you take control. They specialize in transparent, employer-driven benefit strategies that protect your people and your bottom line. Ready to break away from the status quo? Visit www.fixmybenefitsnow.com and discover how Route 3 can help you build a plan that actually works for your team and for your budget.
And welcome back to the Benefit Whisperer podcast with your host, Ralph Weber. Ralph, good to be with you. For those who are joining us, we're sort of in the middle, kind of toward the end of a series that you've initiated on healthcare in America, or how insurance aid healthcare in America.
Yes, absolutely.
So I thought, before we delve into this sixth part, where you're going to take us on a look at what's become of healthcare,
right.
Why don't you give us a quick review so that, if someone hasn't listened, they don't feel like they need to stop right now and run back and listen to everything else first.
I'm a history buff. I feel that if something is not working, you can't just put a Band-Aid on it. You just can't wire it back together. You have to figure out what happened. When a doctor treats a disease, they don't just treat the symptoms. So let's say someone goes to the doctor and says, I've got a headache. Well, take some Tylenol. Okay. Comes back the next week. I still have a headache. Oh, well, take some Tylenol number 3. Here's a prescription. Comes back the next week. Still have a headache. You better take some migraine. So anyway, they just keep giving different prescriptions.
Right.
And then a few months later, it turns out they have a brain tumor. Okay. So that's because the doctor treated the symptoms. Okay. They didn't look back at the history and find out the root of the problem. And that's what happened to healthcare over the last 100 years. We've had an interesting 5 episodes, you and I together, kind of exploring this. I could have gone much deeper, but I think we went over the important stuff. So let's just recap it. Okay. So it started in 1929 during the Great Depression. Hospitals were drowning in debt. People couldn't find jobs. People were being bankrupted by medical bills. And it was a problem. Hospitals weren't getting paid. People didn't have money. Now, the same thing is happening today, Bill. Every minute in America, a new family declares bankruptcy due to medical bills. So the problem was liquidity. The solution was prepayment. So the Baylor Teachers Plan in Dallas formed the first ever hospitalization prepayment plan, which later became Blue Cross. So that's where we started. Then 10 years later, in 1939, Blue Shield was formed to stabilize physician income. Okay, so 1929, Blue Cross stabilized hospital income. 1939, Blue Shield stabilized physician incomes. This really expanded third-party payments. Okay. And this gets a little bit into Milton Friedman economics. You're spending somebody else's money versus your own.
Yep.
Okay. So that's where it started. And then in the 40s, there were wage controls. And during the war, employers wanted to attract good people, but the army needed good people to go and fight the war. So the government put price controls in place. And then later, what they said is, we'll make benefits pre-tax. So that really made them cheaper by whatever the tax rate was artificially.
Yeah.
And then another thing that happened is, instead of paying premiums once a month or once a year, they took it out weekly or biweekly out of your paycheck. So you never saw it. Okay? So all you saw is your net pay after income tax, benefits, etc. Okay, so employees lost even more visibility. Okay, so they lost it with the prepayment, they lost it with the pre-tax, and then they lost even more when it started coming off the paycheck. Think of the IRS. Way back when, people used to pay taxes once a year, then they started payroll withholding. And I don't know the exact numbers, but the amount they collected went way up when they did that. So same thing. So now people aren't seeing this. So what happens is consumption goes up. Now, in 1965, Medicare and Medicaid was formed. So public funding hugely scaled. Compliance expands because now the government is a big payer. Cost shifting became a structural issue. Then in 73, President Nixon signed the HMO Act, which brought in managed care, utilization controls, the gatekeeper model, administrative oversight started to really grow. Okay, and then in 83, DRGs, so the end cost, it sort of ended what used to be sort of the cost plus reimbursement. So in 1983, that's very, very important. So there were fixed payments per diagnosis, and that is super important. Of course, Mark Cuban, cost plus drugs, he's in the pharmacy side going back to that, cost plus. In 83 in medical, that's when we diverged from that. So intensity of coding started rising, and the charge master started inflating prices.
But all right, Rob, I just interrupt you for 1 second here. I know we talked about this, but it's eating at the edge of my mind here. I don't remember what DRGs is. What do you mean when you talk about DRGs?
DRG stands for diagnostic related groups. A diagnosis falls into a group of potential diseases or illnesses. And the coding became more complex. ICD codes, CPT codes, revenue codes, the whole thing. We started to develop this big encyclopedia, and billing, as I said, it used to be that a provider or hospital would say, hey, look, the cost of doing this is $1,000. I'm going to, charge $1,200 or whatever. That stopped. They started billing by diagnosis, not based on how much it actually cost them. So all these things were put in place to solve a problem, and they partially did, but like a balloon, you squeeze it, it comes out somewhere else.
Right.
So then in the 90s, people didn't like the HMO model, so PPOs were formed. And then everybody said, oh, great. Choice has returned. We've restored choice, and the PPOs were supposed to negotiate rates, because if you let the providers charge anything they want, you just never know what they're going to charge. Now, had they not gone to DRGs, that may not have been a problem because the market may have functioned. So they said, okay, we're going to negotiate discounts. But in order to negotiate discounts, we also have to negotiate the inflated prices. So pricing really stopped. But there were no more prices in healthcare. It really became a theater. Then, shortly after that, this is in the 90s, late 90s, early 2000s, a few other things happened. Okay, pharmacy benefit managers, HIPAA,
Mm-hmm.
and then eventually the ACA in the 2010. So more intermediaries, more compliance, more complexity, more risk management layers. So layers.
So what we've got here, Ralph, what you're describing is you've got a process that's becoming increasingly opaque,
Yes,
less and less transparent, and it's
Correct.
becoming multi-layered. So it is now turned into, some sort of Dante's 10 circles of hell kind of thing.
Yeah. I mean, even layers of plexiglass eventually reduce transparency, even if each layer were transparent. Imagine this, Bill. Imagine if you bought something from Amazon and you didn't find out the cost until maybe 3 to 6 months later, and you had to go through 3 or 4 intermediaries to find out what the cost was. Okay. We would never allow
Good
that.
analogy. I like that.
Yeah.
That's good. I can see that. Yeah.
So anyway, the system, it didn't collapse. It compounded, those layers upon layers upon layers. It just made things worse. It didn't solve the problem because there was so much weight. And back when I studied geology, about a million years ago, I learned about geosynclines. That just popped into my head.
Geology professor in college, and we took many field trips. We looked at a lot of geosynclines.
Yeah. A lot more has happened since revenue cycle management started because the payment took a long time. Providers didn't know when they were getting paid, how much they were getting paid. So they had to start something called revenue cycle management. And Bill, the people that are younger than you and I, they entered into hospital administration or payer administration after this has all happened. So that's the norm. Okay. Because anybody who has never turned on a high beam with their left foot wouldn't remember that, right?
That's true. You sneak that little Easter egg in there, Ralph.
Yeah.
You don't know what you don't know. So
Exactly.
after all that layering, what is in all of this stuff that you're talking about, and listeners, you can go back and listen to this more in depth in the individual episodes. What has healthcare become?
Well, we use one word, Bill, healthcare, but it means different things to different people. It's really two different industries. Okay. So on the one half, it's medical care. It's going to see a doctor, going to a hospital, getting treatment, taking drugs, having outcomes. Okay. So it's the medical care. And on the other side, it's healthcare finance. It's the transfer of risk because a really huge event, not a lot of people can afford. So you transfer risk, and whether it's to an insurance company or among a group, billing claims, all of a sudden, claims had to be adjudicated. So risk transfer, billing, claims adjudication, denials, appeals, collections. Medical care itself has advanced dramatically. We're able to cure illnesses and diseases that used to kill people. We're able to cure them now. But at the same time, healthcare finance has become a parallel economy. And Bill, we spend $5.5 trillion a year on healthcare, which is bigger than the GDP of Germany, which is the third largest GDP in the world.
So, I mean, I intuitively understand what you're saying. Anybody who has any kind of healthcare insurance or any experience with the healthcare system understands exactly what you're saying. And it doesn't feel over the course of these episodes that we've been doing that the system is necessarily developed rationally. It feels like there's an irrational component to this made possible by the opaqueness and by the layers and by the decisions to say, we're going to go in this direction and do it this way. And that maybe it's time, we rethink that.
I agree with you, Bill. Now, if you judge it by outcomes, it's completely irrational. We pay more than any other country does for medical care, and we don't get better outcomes.
Hear that all the time.
We get bankrupted. Employers are paying an average of $16,000 per year per employee now. So if you've got 100 employees, that's 1.6 million. That's the average. Okay. So if you judge it by outcomes, it looks very irrational. But if you judge it by incentives, it makes perfect sense. So instead of asking, why is it so expensive? What we should be asking is, what is the system optimized to produce?
And what is it optimized to produce?
Well, liquidity protection. What we have, it's not a pricing problem. It's a liquidity problem, but it's created by, and remember, in 1929, we were trying to solve that problem of liquidity by having prepayments. That's budgetable. But what's happened is the liquidity problem now is actually created by delayed, disrupted, disputed payments. Okay. So when payment becomes delayed and adjudicated, the system becomes a billing and collections machine. And that's what we have now, with hospitals being the biggest collection agencies in the country.
Walk me through this a little bit, Ralph, because I agree. I mean, having been in my share of hospitals and having conversations with building departments, I can understand what you're saying, but walk me through how this works or doesn't work.
Well, as I said, by outcomes, it doesn't work, but by incentives, it does. So in most industries, other than healthcare, whatever that is, whichever side we're talking about, what you have is service or product, invoice and payment. 1, 2, 3, bing, bang, bong. Go to a restaurant, you get service, you eat the food, you get the invoice, you pay. When you book a flight, you book it before you receive the service. In most industries, they're very, very closely aligned in terms of timeline. In healthcare, not so much. Let's expand it.
But Ralph, I've got to stop you for 1 second and say, mostly, like, if I'm going on vacation, I know, so I can book the flight in advance. Or if I'm going out to dinner, there's a decision made, we're going to go out to dinner, right?
Right.
I think healthcare a lot of the times isn't one of those deals where you think, well, okay, I'm going to go to the doctor. Unless it's like for your annual physical. Most of the time you call them and say, look, I don't feel well. Something's wrong. I need to come in. So it is different, but I get what you're saying is that the cost when you sit down, the cost up front, and you pay it when you receive it, and then it's done.
Well, I have an air conditioner, Bill, and it's about 26, 27 years old, and it's still working, and it's a good make, and I know one day it's going to go, and I don't know when that is. Could be tomorrow, could be in 5 years. Okay. So I don't decide when it's going to go. I might decide to have it replaced before it goes, or I might wait
Yep.
until it goes. So healthcare isn't the only industry where things happen that we don't expect. And I want to talk about Kevin Schulman and David Scheinker in a minute, because they wrote something called the BIR supplement, billing and insurance related issues. They studied the life of a bill. And we talked about that before. So in healthcare, you've got service, claim, review, repricing, denial, appeal, delay. So the providers of the service, the hospitals, the doctors, to them, payment, number one, is uncertain. They don't know if they'll get paid. Number two, it's delayed. And there are a whole bunch of hoops they have to
they
jump
can be
through.
humps too, as a matter of fact. But
Speed bumps, yeah. They have to jump through all these hoops, and they have to do all of this administrative works. That is, number one, it adds layers, which we've talked about. But also what happens is really it's adjudication, not commerce. So that's the key.
Well,
it's adjudication, not commerce.
Well, it's weird. I mean, just to continue with the analogy you brought up, we're going out to dinner. You and I go out to dinner. We look at our menu. We order our food. We get our food. Then when we get the bill, we go, wait a minute.
Yeah.
Let's review this. I don't think we need to pay this much. It would become an absurdity.
Yeah. Yeah. No, exactly. Now,
can we call these people over here? We're gonna appeal this because we don't think this is right. I'm going to bring in a judge because I think Ralph and I paid too much for this dinner.
Yeah.
That's just patently absurd.
It is. And a lot of times, Bill, I'll go to a restaurant and I really like what it is, and I'll clean the plate and it almost looks like I licked it. And then the server will come by and jokingly say, well, it didn't look like you enjoyed it much. And of course, because the plate's completely clean. Now imagine if I cleaned the plate and I said, I think it was undercooked, or it was too spicy, or I think you overcharged. I think that the price on the menu, now that I think about it, was too much. We would never think of doing that. If it didn't taste right at the start, we'd say it's undercooked, and they would replace it, cook it more, whatever.
Right.
Okay. But at the time of service, they would do that, and we'd know the price up front. So that's another big difference.
Well, also the restaurant knows the price. The restaurant can understand its cost, right?
Yes.
The system you're describing is irrational in the sense that you get a service, they send you the bill, and you go, wait, nope, well, stop. We got to review this. And then, you know what? We don't like that price. We want to reprice that. And then you got somebody, third party comes in and goes, well, okay, we're gonna, no, that's not good. We're gonna deny that. Ralph doesn't have to pay for that. Ralph and Bill get their dinner for free. The provider for that service at that point has no idea what's going on.
Right.
All they know is that what should be a simple calculation in terms of cost of the service, the cost of the people involved should be relatively simple, and they could enter it into their books, and they could understand where they are in terms of accounting and where they stand in terms of profit and loss, right? Money in and out.
Yeah. No, exactly. I would hate to be a CFO in a hospital, Bill. I mean, after I was an air traffic controller, I studied cost accounting for 3 years, and it was pretty simple. The cost, in a restaurant situation, for example, there's the cost of food, there's the cost of paper, there's the people cost, there's the real estate, there's the rent, there's the costs are relatively known. And if you manage properly, you don't have that much food waste. So you kind of know the costs. In healthcare, number one, you don't know the costs. If you're the CFO, I mean, you do and you don't. You don't know the cost of providing a certain procedure to a certain person. You know that you get reimbursed by DRG, not by cost. So in time, you may discover that some procedures are more profitable. Okay. And you may see that some are less profitable. And hopefully you have enough of a payer mix that, you can make it work for you. Some physicians have specialized in a certain procedure, and they'll just do it all day long because it's profitable for them. But in a hospital that does everything, whether it's children's hospital, adults hospital, kind of a general hospital, not every procedure is going to be profitable because they're priced by DRG. And there's no rationality to that in terms of the expected outcomes.
Well, it also strikes me that liquidity is really hard in this kind of situation.
It is.
Because you talked about the delay in the payment. I maybe you want to expand on that a little bit. I mean, is there anything else? Is there any other industry that works even remotely like this?
Well, we talked about normal industries, buying a car, booking a flight,
Right.
having a meal in a restaurant, buying something from Amazon. The payment cycle is relatively compressed. There is a term that most accountants will understand. It's called DSO. Okay. What it stands for is days sales outstanding, DSO. What it means is the delay between when the service is delivered or the product delivered and the money received. Okay. And that's the accounts receivable portion. So healthcare DSO can run easily 150 to 200 days in a lot of different environments. Okay. Think of that. We're talking 5 to 8, 9 months. That's a lot of delays. Yeah, and that's not normal. That's not normal for service businesses, because service businesses, your biggest cost is your people. It's not like making cars where your biggest cost is making the car, or Starbucks where, well, I mean, we've talked about Starbucks, the cost of healthcare is more than the cost of beans, but the biggest cost is people when you provide a service. So for service businesses, that is not normal, because you can't, if I sell you a widget and you don't pay, I could potentially repossess it. If I sell you a car and you don't pay, I can repossess it, house, et cetera, et cetera. If I take out your appendix and you don't pay, I can't put it back in, right? So I've provided the service. So industries with similar DSOs, think about this. Similar DSOs to healthcare, litigation recoveries, government contracting disputes, bankruptcy claims, insurance subrogation, and that's when you go after different insurance to collect the money, construction disputes. So these are all adversarial payment environments. Adversarial, think about that. So the healthcare business is it's an adversarial payment environment. That's really what it is. And it structurally, it resembles those kinds of industries that we've just talked about more than it does retail.
So what does that do to the internal workings of a hospital?
That's tough. And there's so many vendors that have popped up to say, hey, I can fix that. I've got some AI-based software that'll compress your revenue cycle. And that's like saying, I've got this beaten up old, just wait. Think of a car, a Skoda. What was that AMC? The Gremlin. I've got an AMC Gremlin.
The Gremlin. Good Lord. If you have one of those,
this thing is it's not where it's falling apart. And then you say, well, let's just strap a jet engine on it. Okay. That's what AI does to a broken system. I mean, in parts. So when payment is uncertain, Bill, in any industry. Okay. So number one, the revenue cycle becomes survival. It's sad, but the revenue cycle becomes survival. Billing scales like collections. You have to collect, okay? Coding, doing all of the coding to build the insurance, that becomes leverage. Denials become routine, and administration grows defensively. So complexity itself becomes rational. Not evil, rational.
I just had to pause for a minute to take that all in, because that's crazy. And it does raise the question in my mind, and I think probably most people's minds. So when somebody writes a healthcare check, what are they actually buying? It seems to me they're basically supporting a broken system. They are the jet engine, if you will, to your analogy on the Gremlin.
Yeah. And that's why a lot of systems are opting out of insurance payment. Yeah, I'll do this procedure, but you pay me up front. And they'll take a lot less. One in the hand is worth two in the bush, right? Like money on the table.
Bird in the hand is worth two in the bush, yeah.
That's the one. So they're not buying care. Okay, they're buying risk transfer, claims adjudication, denial management. I had Waris Bukhari on a couple of weeks ago. He's got a company called Claimable, where that's his whole thing is overcoming claims denial. We do We do that every single day. Network access, paying for the PPO that's supposed to have these wonderful discounts. The whole repricing infrastructure and the compliance overhead, which is a huge, huge amount. Then, of course, it's created all of these affiliates, which in themselves are profit centers. Okay, so you're paying all of these profit centers that have to make their own profit, and I mean, really, all you're kind of buying is cash flow smoothing, like structured flow. And I hate saying that because I feel it's something a gastroenterologist should say, or proctologist. I'm sorry, it's Friday.
It's staggering. And you've done a really nice job at laying out the two different worlds of healthcare.
Mm-hmm.
There are the doctors, there are the nurses, there are the people providing care for your health and your well-being.
Right.
And then there is this complex, opaque, complicated, frankly, bizarre financial system that looks like something out of a nightmare at work.
Yeah, it is. So healthcare is functioning like a very complex financial intermediary system. The product is opacity.
Yeah.
The service is collections. The revenue model is complexity. Okay. So you've got opacity, collections, complexity, and the driver is liquidity friction.
So if all of this is true, and I have no reason to doubt that it is in fact true, it seems like reform would be fairly obvious. I don't want to say simple, but obvious. So why haven't any attempts at reform worked?
Well, there have been attempts at reform. They have addressed one or two symptoms. So number one, reforms often don't work because they target the cost. But cost is a symptom.
Okay.
Cost isn't the problem. Cost is a symptom. The structure needs to be fixed. If you're fixing a house, if your house is too small and you're adding a third story and it's built on sand, you have to fix the structure first. So the structure is delayed payment,
Right.
fragmented buyers, third-party intermediaries, opaque contracts. Okay. So reform itself that has been tried, reforms layer controls on top of a claims machine. So all they really do, Bill, is they increase friction, they increase the administration, and that increases cost even more. So the system protects itself structurally, not because of felons, but because of incentives. And that's why it persists. Healthcare didn't collapse. It evolved into an intermediary system that was built around managing payment uncertainty. And until we understand what it has become, we're going to keep trying to fix the wrong problem. We're going to keep trying to fix the symptoms. And in the next episode, Bill, we're going to talk about what restoring liquidity and transparency would actually change. Market, boom, and then I can do the other one here, option B. Okay, so that's a good question, Bill. Where does it leave employers? If liquidity is the problem, then shortening payment cycles, number one, changes everything. And that's where we're going next.
And what does next look like, Ralph, where we're taking us? Because I feel like we're journeying through some really dark circles here that I think most people have never considered, because most people's experience with healthcare has nothing to do with any of this. I mean, yes, there are people going bankrupt from medical costs. Yes, people understand that insurance companies will irrationally, it seems, say no to procedures that are clearly obvious that should happen.
Right.
But most of us go to the doctor and the doctor treats us. And then everything that you were talking about takes place in the background back here where we don't see it.
Mm-hmm. Yeah. Yeah,
so what's next?
It is such a big machine, Bill. We're going to have we've got a really exciting episode coming up, Bill, and you're going to be on it. And we're going to talk a lot about the solution. So let me kind of spill the beans a little bit. As of today, okay, by the time this episode airs, it's going to be about 3 weeks away. March 24th is the episode. It's going to be live streamed and recorded. And we're going to have Mark Cuban on the podcast. Mark has done a lot in the PBM industry with cost plus drugs, and he's been very vocal. And he's the real deal. He's a good guy, and his heart's in the right place. He's working really hard at chipping away at this market. He believes very largely in direct contracting, where an employer has a direct contract with a hospital without the PPO, the payer, utilization, without all that stuff. So he's carved out that. And we also have two individuals, Dr. Kevin Schulman. He is a medical doctor at Stanford Health, I guess, and David Schenker, who has been on this podcast before. David is a PhD healthcare economist at Stanford as well. They have written a lot of studies that have been published. They have written about a BIR supplement, which is billing insurance related issue. They have studied the life of a bill, which we've talked about in previous episodes. Bill, not life of a Bill Tucker, life of a hospital bill. That
Schoolhouse Rock, for those of you who are old enough to remember, go look up Schoolhouse Rock about the life of a bill.
So, Bill, the life of a bill, it goes through 43 steps from when it's initiated to when it's actually paid. And I think I said 5 or 6 of them. The treatment happens, the claim is made, it's denied, it's repriced. But there are actually 43 steps. And so many people touch that item, and the delays we've talked about. So these two individuals, David Schenker and Kevin Schulman, have studied this a lot. Mark Cuban is out there practicing this. He's putting things in place. We're going to talk about this, and it's going to be a very insightful conversation.
I'm looking forward to listening to this because Mark is somebody who's put his money where his mouth is. He's been very vocal about this. And, you have mentioned him. You mentioned him earlier in this podcast. You've mentioned the other two gentlemen as well over time in multiple podcasts. So that, I'm looking forward to this because I think this is one of the most important issues of our time.
It is. It's the number one reason for bankruptcy. Yes, our life expectancy has increased over the last 100 years. However, I'm gonna be so bold as to say our financial life expectancy hasn't. Okay, with all of these costs, the fact that it consumes almost 20% of our GDP, $5.5 trillion. David Schenker said something very meaningful. Out of that $5.5 trillion, $1.7 trillion is paid for administration and payment of medical care. $1.7 trillion a year.
That just absolutely stuns my imagination.
Yeah, I think I'm not sure, but I think that's probably as much or more than the defense budget.
Offhand, I don't remember what the defense budget is, but it sounds like a much larger number than the defense budget, as a matter of fact.
Yeah.
And it's an issue that it doesn't affect some Americans. This is an issue that affects literally every American. I don't know anybody who this doesn't touch.
Yeah. And it's been, for me, Bill, these last 6 episodes have been very, I don't know if rewarding is the right word, insightful. I think as we go through it, as we look at what's been done, why it's been done, what it was supposed to do, what it ended up doing, and why none of the reforms are working. I think that this is, if anybody's listened to all 6 episodes and is going to listen to the one with Mark Cuban and Kevin Schulman, I think they will be very well educated in the finances of healthcare.
Well, I told you when we first started discussing this is a really ambitious attempt to sort of break it down and lay it out for people to see. And I also completely supported your idea that it's like you can't fix something that's broken if you don't know what's broken. So, and you've done a really good job at doing that. For listeners who are not subscribers, I would encourage you to go back and listen to the other episodes and give you a little bit more filled in version of everything that Ralph and I have kind of reviewed here today, plus where we are now. The beauty of being a subscriber, though, means that you don't have to remember when that podcast is going to come out. You will get a notification and it will drop and you can listen to it. And if you miss the live stream, and Ralph will be promoting that live stream on his social media feeds, fear not, because Ralph, they can also hear it, right? They can go back and hear it after it's been recorded.
Yeah. Exactly. We hope, Bill, that this is making people think more about the finances of healthcare, but their finances of their company and where money is wasted. And we all the time, every day, we talk to employers, large and small, and in between about how much they're paying for healthcare costs and understanding this. It's more than just understanding that premiums go up because name 100 reasons, but understanding the speed bumps, the hoops, the layers, understanding that and being able to see through all that. Just like an air traffic controller, being able to see with radar precision through the clouds to know the airspeed, the rate of climb, the rate of descent, what all of these atmospheric conditions and airplane characteristics do to air travel. Bill, when I was an air traffic controller, I had to stand up in the midst of chaos, figure out what happened, and sort it out with no mistakes. And I do the same in healthcare. It is just as complicated.
Well, you and I have been doing this podcast together for a while now, and I will stand and testify that it is intensely complicated, which I think makes reform all that much more important, number one. But I wish it were simple, and maybe it is, and maybe Mark and these gentlemen will present us with a case where it's not hopeless.
Yeah.
There can be reform undertaken now.
Right. Yep. Absolutely. Mark didn't get to where he is, and he hasn't done some of the things that he's done by not being smart. And we're so lucky to have him focus on healthcare being such a big issue. And I'm really looking forward to these very, very well studied people talking about this and really unpacking it.
It's going to be great. So hit the like and subscribe button, folks. If you're not already a subscriber, become one. Don't miss the next episode of The Benefit Whisperer. For those of you who are listening to this and thinking that you might, as an employer, benefit from a conversation with Ralph about how you can get your healthcare costs under control, Ralph, what's the best way for them to get a hold of you?
Well, they can email me, Ralph@thebenefitwhisperer.com, Ralph@thebenefitwhisperer.com. Can follow me on LinkedIn. I'm easy to find, LinkedIn/Ralph Weber. It's very simple. Visit fixmybenefitsnow.com and go to the contact page and you'll find me. I'm there. Happy to have a 15-minute consult with anybody and talk about their healthcare.
And remember this, folks, if nothing else, when you're thinking about the next episode, the fact that Starbucks spends more on healthcare than it spends on coffee beans tells you graphically how large this problem is. So don't miss the next episode. On behalf of Ralph and everybody at the Behind the Benefit Whisperer podcast, I'm Bill Tucker, thanking you for taking the time to listen. And I know we're going to catch you next time.
You bet. Thanks, Bill.
Thank you.